Assalamu alaikum and good day. I am Johara Adtha, and for today, I'm going to discuss the endocrine or metabolic disorder in pedia. Endocrine and metabolic disorders as a group commonly cause changes in growth in a child's social and physical development and may impair their cognitive development. So these disorders are often manifested in growth and development delays, especially during puberty or adolescence. So if not identified at birth, the disorder is usually detected when a child's height and weight are measured at a healthcare visit and found to be above or below a typical measurement for that age. So children with endocrine disorders are almost all long-term disorders. So helping parents and children remember to take medicine on a long-term basis is an important nursing responsibility that not only meets competencies but that also meets the family's total needs. So one of the endocrine or metabolic disorders is the growth health deficiency. So if production of human growth hormone or somatotropin is deficient, children are not able to grow to full size. As a result, children may appear well proportioned but measure well below the average on a standard growth chart. So deficient production of GH may result from a non-malignant cystic tumor of embryonic origin that places pressure on the pituitary gland or from increased intracranial pressure as a result of trauma. So the physical assessment of this disorder are first, the child with deficient production of growth hormone is usually normal in size and weight at birth. But within the first few years of life, however, the child begins to fall below the third percentile of height and weight on growth chart. So the face appears infantile because the mandible is recessed and immature, and the nose is usually small. Then the child's teeth may be crowded in a small jaw and may erupt late. Then the child's voice may be high-pitched and the onset of pubic, facial, and axillary hair and genital growth will be delayed. So the history, physical findings, and a decreased level of circulating GH contribute to the diagnosis. Second, as part of the history taking, evaluate the family history for traits of short stature or constitutional delay and if at all possible, obtain estimates of the parents' height and siblings' height and weight during their periods of growth. So assess the child's prenatal and birth history for any suggestion of intrauterine growth restriction. Assess also for any severe head trauma that could have injured the pituitary gland or chronic illness such as a heart, kidney, or intestinal disorder that could have contributed to the decreased level of growth. Then take a 24-hour nutrition history to see if picky eating habits are extensive enough to halt growth, and be certain to assess not only the child's actual height but also his or her feelings about being short. So, a physical assessment including a fundoscopic examination, neurologic testing, and blood analysis for hypothyroidism, hypoadrenalism, hypoaldosteronism, and growth factor binding proteins are also helpful in ruling out a lesion or tumor. So bone age is established by a wrist X-ray, skull series, computed tomography, scanning, magnetic resonance imaging, and ultrasound. This will be prescribed to detect possible enlargement of the sella turcica, which would suggest a pituitary tumor. So the medical or therapeutic management for this disorder is that growth hormone deficiency is treated by the administration of intramuscular recombinant human growth hormone, usually given daily at bedtime. the time of day at which growth hormone normally peaks. So in addition, some children may need suppression of luteinizing hormone-releasing hormone or gonadotrophin-releasing hormones. So this is to delay epiphyseal closure, and other children may need supplements of gonadotrophin or other pituitary hormones if these are determined to be deficient as well. So we have this drug for these disorders such as the somatropin, notropin, eumatrope. So its classification is somatropin. So it is an example of a recombinant human growth hormone. So its mechanism of action is for the long-term treatment of children who have growth failure from inadequate production of pituitary hormone, renal failure, or Turner syndrome. So it is a pregnancy risk category C. So its dosage is somatropin dosage is individualized. So this drug is administered by injection, either ST or intramuscularly. So the possible adverse effects are injection site pain, glucose intolerance, hypothyroidism, bone problems, particularly in the hip, blood abnormalities, rare intracranial hypertension in first 8 weeks of therapy. Then the nursing implications of this drug are: advise parents that x-rays of the wrist or hip will be performed before therapy begins. Thereafter, parents should be alert for limping or knee or hip pain, which should be reported to their primary healthcare provider because sleep capital epiphysis is associated with RHGH supplementations. Second, reinforce the need for periodic thyroid function tests and fundoscopic examination to detect rare intracranial hypertension. Third, alert parents that RHGH may interact with glucocorticoid therapy such as prednisone, causing a decrease in the effectiveness of the RHGH. So, urge parents to inform all healthcare providers that the child is receiving RHGH to avoid this type of interaction. Then the next one is the nursing diagnosis and outcome evaluation of this disorder. So the nursing diagnosis is situational low self-esteem related to short stature, and the outcome evaluation is child speaks positively about self, identifies friends and activities enjoyed with peers. So the nursing interventions for this are: first, if a child has been consistently behind in growth since early life, parents may simply assume in early childhood that the child is going to be short as an adult. So the parents then may become concerned that something is wrong only after the child reaches puberty and fails to develop secondary sex characteristics. So if an investigation at that time reveals the child's true problem is a lack of GH, parents may feel guilty that they did not become alarmed earlier. So they may feel resentment toward healthcare personnel who did not alert them to the problem earlier. Second, encourage parents to discuss these feelings and provide support to help them accept their child in this new light, as well as participate in making the new plan of care a success. So children with short stature tend to report feelings of lower quality of life, largely related to discrimination. Then third is you may need to remind parents to assign duties and responsibilities to children that match their chronologic age, so not their physical size, in order to promote children's feelings of maturity and self-esteem. Then lastly is because children different in any way from their peers may be the victims of bullying, alert parents to this possibility and assess for this at well-child visits to help protect the child's quality of life. So that would be all for the endocrine or metabolic disorders. So thank you for listening and goodbye.